Clinically, shock is defined as a systemic state of low tissue perfusion that is inadequate for normal cellular respiration. It is a strictly mechanical failure of delivery, entirely untethered from the numbers on a blood pressure cuff. This creates a very dangerous clinical paradox. A patient can sit in front of you with perfectly normal blood pressure, while on a microscopic level, they are actively sustaining lethal organ damage. This state of invisible cellular starvation is called occult hypoperfusion. By relying on hypotension, low blood pressure, as the primary indicator of shock, a practitioner guarantees a late diagnosis. This delayed diagnosis poses the greatest risk to highly compensated populations, particularly fit young adults who can aggressively mask fluid loss, or elderly patients whose heart rates are artificially controlled by beta blockers. To identify shock before it reaches a terminal threshold, the macro illusion of normotension must be ignored. The focus must shift to the exact mechanical failures occurring at the cellular level. To maintain structure and function, healthy cells demand continuous oxygen delivery to power aerobic metabolism. When hypoperfusion reduces oxygen delivery, the cell initiates a forced metabolic shift, abandoning aerobic processing for anaerobic respiration. The byproduct is no longer harmless carbon dioxide. It is lactic acid. As thousands of underperfused cells expel this waste, the accumulating lactic acid creates a systemic metabolic acidosis. As intracellular glucose is exhausted, the critical sodium and potassium pumps freeze, allowing water to flood the interior. The internal architecture begins to collapse. Intracellular lysosomes burst under the stress, releasing autodigestive enzymes that consume the cell. This culminates in cell lysis. The swollen membrane ruptures, violently releasing intracellular potassium into the bloodstream. What began as a localized microscopic oxygen deficit has now become a systemic toxic spell. The release of potassium and lactic acid dramatically alters the local tissue environment, directly activating the immune and coagulation systems. The dual presence of hypoxia and acidosis primes local leukocytes. These white blood cells begin generating oxygen-free radicals and releasing inflammatory cytokines. This aggressive immune response immediately injures the surrounding capillary endothelial cells. As the damaged endothelium loses structural integrity, widened spaces form between the cells. Fluid leaks rapidly out of the vasculature, causing severe tissue edema. This accumulated fluid physically increases the distance that remaining oxygen molecules must travel to reach surviving cells, creating a self-sustaining loop of worsening hypoxia. As fluid leaks into the tissues, the vascular system loses pressure. Compensatory baroreceptors detect this drop and trigger massive sympathetic nerve activity. The body releases a flood of catecholamines. This induces immediate tachycardia to increase pump speed, and severe peripheral vasoconstriction to forcibly redirect remaining blood flow strictly to the brain, heart, and lungs. Simultaneously, the brain registers the spreading metabolic acidosis. The respiratory system increases minute ventilation, attempting to rapidly vent carbon dioxide and balance the blood's pH. Decreased perfusion to the organs triggers the renal system. The renin-angiotensin-aldosterone axis activates, forcing the kidneys to aggressively retain sodium and water. This renal clamping directly manifests as severe oliguria, a drastic reduction in a patient's urine output. The classic clinical signs of early shock: cool, pale skin, a rapid pulse, quickened, shallow breathing, and low urine output are all evidence of the neuroendocrine system actively sacrificing the body's periphery to delay complete collapse. The terminal event of cell lysis is identical in every fatal case, but the initiating mechanisms of shock are classified into 5 distinct categories. Hypovolemic shock is driven by a primary loss of circulating fluid volume. The result is a low cardiac output from the pump, paired with tightly constricted pipes, creating high systemic vascular resistance. Cardiogenic shock is a primary failure of the heart muscle itself. It mimics hypovolemic output and resistance, but fluid visibly backs up into the venous side, raising venous pressure. Obstructive shock occurs when a mechanical block, like a pulmonary embolus, prevents the heart from filling properly, again resulting in a severely low cardiac output. Distributive shock, seen in sepsis or anaphylaxis, behaves differently. Pathological vasodilation causes the pipes to profoundly widen. systemic vascular resistance drops severely, leading to an abnormally high cardiac output that still fails to perfuse the organs. Finally, endocrine shock exists as a hybrid state, marked by low cardiac inotropy and an unresponsiveness to the body's own circulating catecholamines. Whether the initial failure is the pump, the fluid, or the pipes, the resulting hemodynamic failure leads to the exact same path of cellular starvation. This chart compares a patient's blood pressure against total circulating volume loss. The body's aggressive compensation maintains a normal blood pressure until 30 to 40% of volume is lost. The pressure only begins to collapse after crossing this threshold. This marks the transition into decompensated shock. Renal mechanisms fail completely, patients become drowsy, and only now does severe hypotension emerge. At this stage, the heart itself begins to suffer direct myocardial depression from the severe acidemia and hyperkalemia circulating in the blood. The patient enters unresuscitatable shock. The peripheral vascular system completely loses the ability to maintain resistance, and tissues no longer respond to vasopressor medications. Waiting for a patient's blood pressure to drop means waiting until their compensatory mechanisms have entirely broken down. By that point, systemic ischemic injury is so advanced that death is inevitable. For those caught in time, there is a final medical paradox. Successfully restoring blood circulation to ischemic tissues can deliver a fatal blow. This is ischemia reperfusion injury. Restoring normal blood flow flushes this built-up acid, potassium, and dead cellular material violently back into the central circulation. This sudden toxic flush overwhelms the local anti-inflammatory response and triggers systemic inflammatory response syndrome, or SIRS. Circulating leukocytes, complement proteins, and microvascular thrombi are blasted back into the systemic circulation, where they cause massive secondary injury to distant, previously healthy organs. The consequences are immediate and catastrophic: acute respiratory distress in the lungs, acute renal injury, and profound cerebral swelling. This is multiple organ failure, the endpoint of reperfusion injury. It carries a 60%